Timis, and thank you, Dr. Ndwapi, for walking us through and setting up the stage. I will be talking to you from the implementer perspectives about my experience. I will start by overviewing briefly where are we with adolescents and long-acting ART, what do we know about the desirability, and then we will move on discussing the experience of our program implementing this program as a standard of clinical practice and not in the settings of the clinical trial. I have no conflicts of interest and my disclosures are here. So long-acting for ART, yes or no? We all know about adolescents. Linda Gale Baker set up a beautiful stage on Wednesday highlighting these populations' progress and challenges. We all know the opinion can change in 15 minutes from yes to no and back. And we all know they live by far more busy lives than you and I do. And we need to fit into the life schedules. So I will start by overviewing the study that is US-based. The survey conducted in 2016 and 17 across 4 different jurisdictions of the United States with very high prevalence of HIV. And those include Baltimore on the East Coast, and then 2 southern states, Atlanta and Memphis. And 2 southern cities, Atlanta and Memphis. And in these 4 clinics, the investigators surveyed 303 youths. They surveyed them prior to the rollout of long-acting ART, and they asked them, are they interested in an injectable long-acting ART? You can see here that the majority of youths were Black African-American, which is in line with epidemic in the United States. You can see that the majority, 74%, were horizontally acquired HIV, and the majority were older than 20 years, 20 to 24 years, but over 40% were under age of 20. 60% of those youths had viral suppression, but if you look at the desirability of getting injectable ART, you see it's pretty high. Slightly low in Memphis. There was an anonymized survey there, so we think it could have changed the desirability bias, but overall above 90% and above 85%, which is, by the way, higher than any of the adult studies that were conducted in the air prior to the rollout of injectable treatment. And when the investigators asked the youth what schedule they would prefer, you can see the first 2 bars are low. These were weekly and bi-weekly injections, but you can see that the acceptance is going quite high with once monthly injections over 85% and bi-monthly injection, and the highest over 90% if the injections were to be given every 3 months. But what's interesting here, what they did, they took this youth and they analyzed the viral load suppression and whether there was any relationship between being suppressed and desiring long-acting injectables. And not surprisingly for many of you, and not surprisingly for me as a clinician, that was the group who had highly detectable viral load, about 1,000 copies, who desired the most and said they would most definitely be interested in long-acting ART compared to those who were undetectable or had low degree viremia below 1,000 copies. Well, let's look at the emerging data. I showed you the data from United States use. The paper by Ilona Tosca and group of Lucy Kluver was just published recently. And in this study, they surveyed 953 adolescents from South Africa. They surveyed them prior to the rollout and approval of the drug for the use, even in adults, in 2017-18. But interesting enough, only 12% of the surveyed youth who expressed interest of any form of long-acting ART, would it be injectable or implantable, over the oral or pill formulation, would it be 1 pill or multiple pill daily dose. And in a multivariate analysis, they have looked which factors were associated with higher likelihood of youth being interested in the injectable form or implantable form. And these were medication stockouts, experiencing side effects, pill burden, past year treatment changes, HIV stigma, and recent ART initiation. And then they looked at the marginal effect modeling, and it actually confirms the motion that I'm setting up, that we are having most likely desirability for that form of treatment currently among those who experience challenges with the oral treatment compared to those who are doing well. Well, let me switch and talk a little bit about what's going on in adolescent arena and what we have done in our clinic. Dr. Ndwadi already has highlighted the line of approval. I just want to highlight that the first approval came in January 2021. It was for adults, it was monthly injection, it was oral lead-in. But then in February 2022, oral lead-in became optional, and you could offer the patients bi-monthly injection. In adolescents, all of these approvals are 18 years and older, and then the lowered initial, and then the lowered approval to 12 years. And 12 years and 35 kilograms. That approval came from Impact Study 217 called MOCA study. It is now fully recruited with 155 participants under the age of 18 years. And the study had two cohorts. The first cohort looked primarily at pharmacokinetics and safety data. And in this cohort 1, they had given only one injection, either cabotegravir or rilpivirine, with continued oral optimized regimen. In a cohort 2, which is ongoing, has 100 participants, they're actually switching virally suppressed patients to the cabotegravir or rilpivirine, and we shall see the results of this study next. And then there is another trial in those under age of 18 that started recruitment in the fall of 2022. The study is called LATA, and it is a study that conducted among youth in Kenya, South Africa, Uganda, and Zimbabwe, youth 12 to 19 years of age. And these are treatment-naive patients, and they're either randomizing to start them on long-acting cabotegravir rilpivirine or the first-line ART with DTG, 3TC, and TDF. So it will be very interesting to see this comparison and this study going forward. The journal criteria have been highlighted, and when we started in our clinic looking at who would be eligible, we started by doing a two-prong. One, we pulled all our patient databases, and we looked back and we used this major criteria. Who has been persistently suppressed with viral load below 200 copies? Who has known, we measured down to 20 copies, but 200 is a federal definition of viral suppressed, and we also use it for U=U conversation with young people. We wanted to see if we had any records of resistance. We have very elaborate resistance database, no HBV infection. And then what we did in the clinic in parallel, we asked in 2017-18, every young person, if we had to bring injectable ART, would you be interested in having this conversation? And about 30 to 40% of our youth expressed interest. And then what, very important caveat, they needed to agree to come to clinic every 1 to 2 months to get the injection within 2 weeks time window. And it's an important consideration because I think, Simisa, you mentioned, and Dr. Ndwawe mentioned, migrant workers, college students, young people with busy lives, are they able to commit to that schedule? Data start emerging, and this is very interesting data set that I recently found in the PIVA, British HIV Association guidelines page. They actually looked at the cohort of 121 youth and wanted to see who would be eligible for long-acting ART. 40% were deemed ineligible. The other had resistance mutations, they had a high BMI over 35, or they had recurrent loss to follow-up, so they really were not engaged in care. The good news here that 60% were eligible. And the way they approached this 60, they broke it down into sub-cohort. Once 34% met all eligibility criteria, and actually 2 of them were already on long-acting ART, and then the other 26% were eligible, but they would require close monitoring and multidisciplinary team engagement because some adherence issues in the past, BMI being borderline to cross to 35, had previous side effects within an RTI, and historical periods of ART being off treatment but no resistance mutations. So let me switch gears and just in a remaining time walk you through what we have done at Children's. At Children's Hospital, we're located downtown DC. It's an area of epidemic in US. Our HIV prevalence is 1.8%, and our clinic cares for about 220 infected infants, children, and adolescents to 24 years of age before we transition them to adult care. In our clinic, we launched it very promptly. We wanted to start immediately after January. It took us 9 months to do all organizational preparation and to figure out the insurance coverage barriers, which are in the United States very significant. We have to address the cost of the drug. It's currently still quite high, so you cannot really go on this treatment without having insurance picking up the cost. So we spent 9 months preparing the mechanism by which we could actually do it. And we also spent 9 months working with our pharmacy. We're a hospital-based clinic. This is an outpatient drug. Our inpatient pharmacy cannot carry it. So we made an arrangement with an outpatient commercial pharmacy in our building that they would procure the drug for the patients, but we would need to register them in our inpatient pharmacy because we're administering them in our clinic premises. We started offering our first patient injectable ART in October 2022, and I'm happy to say we have now that young man who celebrated 18 months on long-acting injectable treatment. And then as soon as the approval was granted in February, we switched to bi-monthly injection and dropped oral lead-in. I don't want to say we did. We started telling our young people, this is your option not to do oral lead-in, and majority of them would have chosen it. We also did online training of our nurse practitioners who administer the injections first, and that online training is available on the website, but VIV site. But then what we also did, we contacted VIV and we invited a nurse practitioner who specifically trained our staff in this injection technique, which, Simisa, you highlighted, is a bit tricky to learn, but it's very, very learnable. We had to change our clinic flow, and I want to talk about this practical consideration. We were oral medicine clinic. We only did flu shots for our patients on yearly basis. We are not primary care clinic. We have not given injections on regular basis. So we created injection space. We created injection storage. We also started with our first patient's injection visit took 1.5 hours. The goal is to bring them under 30 minutes. Young people don't like to wait, and I'm happy to say we have now quite a few visits that are under 30 minutes. Total duration time from the time the patient shows up at registration desk to the time that they walk out of the clinic premises. We had to change our algorithms for blood draw. We did not know how to monitor these patients. So what we decided, we started measuring viral load before each injection. Does it need to stay this way? I'm not sure. We are still working on what the best monitoring schedule would be, but that was what we agreed to do. We developed for each patient who was going to go on injectable individualized plan for missed doses and planned to access oral medications in case we cannot bring them in this 2 weeks time period. And of course, our biggest fear was, what do we do if we miss this 1 week prior to injection, 1 week after injection? The formal guidelines is that you need to start patient on oral cabotegravir and rilpivirine until next injection, up to 2 months. So we needed to make sure that the local pharmacies where they live or the pharmacies that deliver them drug have these drugs, and in case something happens, we can quickly procure these drugs to them. Obviously, you need to know why this happened, why the patient missed the window, and what's very important, if the patient says, I don't want to do it anymore, you need to have a plan in place. So we developed a standard operating procedure discussing all these points with patient when we start them on treatment. This is a very glorious picture of our nurse who has been working with our program for over 35 years. You see her here unpacking the box and joyfully smiling. For one of our patients on injections, the few days before her scheduled second injection was scheduled, insurance discontinued the coverage. So basically, it was a glitch in the system. She could not get the drug. So our nurse, Kim Bright, who is on the picture, spent 12 hours on the phone with different stakeholders, arranging for the drug to be delivered by the courier urgently to clinic, and we still managed to administer it to this patient within the last 12 hours of the dosing window, and you see her gloriously smiling here when we got the drug in the clinic while patient was already there. What have we learned? The technique really matters. Simisa, you highlighted. It's a special technique. It's very teachable, but it needs to be slow, the injection, to avoid injection inside the blood vessel. And we have learned that young people tolerate injections quite well. I will show you our numbers now. We were very worried about pain in the beginning. The first patient was very muscular, strong young man. He weights lifts. When he's disagreeing with me, he simply takes me and puts me in another room of the clinic office. He is very strong. The getting shot for him seemed no-brainer. The second patient was very skinny girl, and we wondered how would she take a loading dose of 3 milliliters injection in each buttock, and she did fine. So it tends to decrease with repeat use. Young people are saying it hurts less and less each time. We have not seen much of the common adverse reaction, but we did see in our 2 first patients a severe adverse reaction within minutes of administration. We discussed with, we reported it. I will not spend much time on it. We have a report in progress but I'm happy to answer any questions about it. This reaction was one time, it self-resolved without any treatment, and it never occurred before, and both patients continued on the treatment despite experiencing it. When we started the program, there was reluctance from providers. There is no question about this. There were a lot of questions asked. What to do with patients with adherence challenges? What is the risk of resistance if we miss the window? Do we need oral tests to all adolescents just to make sure they are committed? And then we have observed and what to do when you see a viral blip on injectional therapy. Does prior exposure to an NRTI matter? And I will be open with you, even that nurse whose picture I showed you, Kim, after the first discussion about long-acting being implemented in our clinic, she came to me one-on-one after the meeting and said, I don't feel comfortable doing that. It's 2 drugs, it's injections, we've never done it. Why should we switch? Why shouldn't we just stay with oral? It works well. But now she's a champion of our injection program. We did publish a letter to the editor, and I won't dwell in details, but it was a bit disappointing in the beginning. Within the first 4 patients in our program, the report that we published reports only 3. We now have 4 out of first 7 patients. We have seen intermittent viremia. And we are talking about young people who had no detectable viral load for 12 to 29 months. And the viremia occurred here, showed on the picture, different time points. It occurred up to 1,000 copies in patient 1, and patient 2 very low, 108 copies, in another patient just close to 1,000 copies, and it occurred in patients who were perfectly on schedule, and it occurred on the day of injection. That's when we measured it. Now, we brought them all within 2-3 days, and they all resuppressed. But nevertheless, particularly for those who are practicing U equal U and your viral load above 200, that was an important decision-making, and we did share decision-making with all young people in the program, what way to take forward. We don't know the nature of this viremia. Could it be that depot in young people behaves different because most of the studies have been done in the patients over 34 years of age? We don't have currently an answer. We were able to do resistance, archived resistance testing, and 2 of them during the viremia did not see any cabotegravir or rilpivirine resistance. And what we agreed with all young people making the decision themselves that we switch them all to monthly injections. By the way, all of these high viral blips occurred at the time of transition to bi-monthly injection, and we would keep them on monthly injections for 6 months, and if they stay undetectable below 200 copies, we will switch to bi-monthly injections. And I'm happy to tell you that the first patient just elected to choose back to bi-monthly injections after being 6 months undetectable. So we are monitoring this very close. Here you can see the 2 first young people in our clinic who switched to injectable drugs. They are holding in their hands the oral drugs. These patients had no issues with adherence. They were sustainably suppressed for many, many years, but they really enjoy the switch. And one of them on the left to you is actually the one who celebrated 18 months, and he said he doesn't want ever to consider going back to oral. He enjoys being on injectable. It's a great experience for him. One of our patients is now refused oral during oral lead-in. She wanted oral lead-in to try to see it, and then halfway in oral lead-in called back and said she did not want to do it. And the primary reason was her schedule in the college. She just cannot commit coming to us to get injections on monthly and even bi-monthly basis. And we have now 14 patients on long-acting ART and 4 patients lined up to stop very soon. And we started 2 complex patients, and I want to quickly highlight one of them. It's a very obese young lady. She had multiple failures on oral regimen. Her BMI is over 39, and she is really, for her, to me, it's life-saving option. Her CD4 count is less than 200 cells. She is a big concern because she's female. There is a very high BMI. We reached out to VIF. We started her on cabotegravir and rilpivirine. We're injecting it in the thigh. We obtained a very long needle specifically for injecting into the muscle. And we actually are waiting for insurance approval for lenacapavir, which we want to add to her schedule to protect cabotegravir and rilpivirine from failure. In conclusion, I want to say that our experience and how we've gone through that definitely shows an incredible potential of long-acting ART in children and adolescents. I didn't talk about children, but there is a lot going on with different long-acting modalities, from broadly neutralizing antibodies to other consideration for younger kids as well for prevention and treatment. Adolescents could greatly benefit, and I agree with you, Simis, it's not for all and it's not for everyone, but that option needs to be there. The young people in our clinic are very happy to have switched. They enjoy it. They say that it's improved the quality of life. I do want to say we're conducting formal survey right now among them, and I will be sharing results soon on the long-term follow-up on being on injectable formulations. There is no doubt in your mind, in our mind, in the mind of my providers who are already doing it, there are still a lot of questions remaining. How are they accepting it, implementation challenges, but we need to gather their feedback. As Linda Gale Baker said, we need to hear youth voices. What do they want? And if they want it, we need to work to deliver it for them, even if it's difficult for us. And I think collecting real-world data is critically important, and the community voices is critically important as well. With that, I will round up, and using my chair privilege, will pass on to my colleague, Kenley, who is going to take us to community journey. Thank you for listening.